Attendees are in listen-only mode.
Hello everyone, this is Karen Scott with TruCode, and it's my pleasure to introduce our speaker today. We are going to be talking about CDI, a broader perspective, and we're here today with Joy King Ewing. Joy is an RHIA, CCS, and CCDS, and she is an AHIMA approved ICD-10 trainer. Joy has lots and lots of background. She's had over 30 years of experience in health information management, and she's worked for HIM departments, the Alabama Quality Assurance Foundation, the Florida Medical Quality Assurance Association. She's worked for several different consulting firms, and she also has her own consulting firms, and we are very pleased to have her here with us as she works with TruCode as well. So we are very happy to have Joy with us today, and I know you guys are going to learn a lot. So Joy's going to go ahead and drive the screens. A couple of things I want to talk to you about before we move on. So if we could move to the second slide, please. And
I'm doing my best. Oops, sorry. There we go.
All right, thanks. One thing I want to mention to y'all is that next month we will be at the AHIMA National Convention. Very excited to go to AHIMA. We are going to be at booth 1420, and we are going to have a fun time there. We'll want you to test your coding skills with our TruCode Challenge, and you could win a Bluetooth speaker. So make your plans to go. Let us know if you're going. We'd love to know that. We'd love to get to meet you in person. Joy and I and Sharon will all be at the booth, and Becky, all the people that you may have known and loved from TruCode are going to be there. Now let's talk about how to have a great, successful presentation today. Just a couple of things that you guys will want to know. Joy, if you'll go ahead and move to the next slide. Basically, everything is going to be run today from that control panel, which is on the right-hand side of your screen. And so it may get in the way. You may want to get it out of the way. And so notice in the middle of the screen there, it shows that click here to open or close. There should be a little orange box with an arrow at the very top of your control panel. All you have to do is click on that, and it will open or close the panel. Now if you want to ask questions, that's shown on the next slide. Toward the very bottom of that panel, there is a question button. All you have to do is click on the plus sign next to the question, and it will open up, and it will allow you, it'll say enter a question for the staff. So if you have any questions, please let us know. If we have time at the end of the presentation today, we will open it up for questions. So again, you're in listen only mode, so you won't be able to ask her a question except in the typing in doing it with the question. You may also notice that there is a handout button right underneath the question button, and that's where your handouts are for today. So you can click on that handouts and you'll be able to get that as well. And then we'll also remember too that you're going to get an email, I'll talk more at the end, but you're going to get an email with an evaluation survey, and that was how you get your CE. So I'll talk to you more about how you get your CE at the end of the presentation. Okay, Joy, I'm done with my part. I'm going to let you go ahead and take it away. Thanks, everyone.
Thank you, Karen, for that introduction, and welcome everyone to this presentation on CDI programs. I'm going to flip back for just a moment to my first slide just to point out a couple of things. My goal today is to try to give a broad overview of how all of the different changing models, payment models that are coming at healthcare today are going to impact, change, and broaden CDI efforts. When CDI first came into being, it was really considered to be a concurrent documentation improvement program. And as you can see, I've got the word concurrent crossed out, although many of those efforts still are occurring on a concurrent basis while the patient is receiving care. But I've changed that and broadened that to clinical documentation. And rather than improvement, I've crossed that out and added the word integrity, because I think you're going to find out as we talk through the different things that we're talking about today that the integrity of that documentation is going to be extremely important as we move into the new payment methodologies that are out there. This is just sort of a snapshot of the evolution of healthcare reimbursement. We started out, of course, in Category 1 with fee-for-service, which is how hospitals got paid and physicians as well, and based on volume. So you basically got paid a certain amount of money for the number of patients that you treat, the number of services that you give, etc. And moving into, and an example down there is that pay for reporting, the IQRP. Moving into Category 2, where we start moving into the value-based reimbursement models, We have quality outcome measures that we've been dealing with for quite a while, and we've been looking at cost outcomes and that kind of thing. And you can see on the bottom of the slide there the examples of those value-based purchasing things, and we're going to talk on touch on each one of those briefly during this presentation. Then moving into category 3, the alternate payment models built on a fee-for-structure architecture. Those are based on selected populations with value-based reimbursement going on. That involves the bundled payment care initiative, the comprehensive joint replacement initiative, accountable care organizations, etc. And then finally, the last category out there, which we haven't moved into quite yet, is the population-based payment models. And the example there is the Pioneer ACO, or the Pioneer organization, that after the first couple of years of operation where they demonstrate that they have a certain amount of cost savings, they're able to move into more of a population-based model that is flexible and based on the organizational values and the market conditions where they are actually operating and caring for patients. So where we're headed, all of these years since we went on DRGs in 1983, we have been basically getting paid for for the number of people that we treat, and as the quality measures were implemented, we got paid based on whether we reported appropriately on those quality measures. Now we are moving into a whole new arena where we're going to actually get paid based on how we perform what we do. The goal of HHS is to have 85% of Medicare reimbursement tied to quality by 2016 and 90% by 2018. There are several value-based payment initiatives developed by CMS listed on this slide. We're going to touch briefly on each one of those. The Hospital-Acquired Condition Program, which has been out for a while. The Hospital Readmission Reduction Program, which has also been out for a while. The Hospital Value-Based Purchasing Program, which we have been sort of implementing in stages for a while. Then we have claims-based outcome measures and associated risk adjustment methodologies that are impacted by documentation and code assignment across the whole continuum of healthcare. Starting with the AHRQ risk adjustment for PSI 90, which is a weighted composite of 8 safety indicators related to in-hospital complications and adverse events during procedures. The risk adjustment that CMS is starting to apply to readmission measures, the risk adjustment that CMS is starting to apply for mortality, and the HCC risk adjustment for efficiency measures. All of these are going to have a huge impact on the way we move forward with payment, and therefore I think a huge impact on the documentation that CDI is trying to capture and that coders are trying to code and bill. Since all of these have a lot of risk adjustment built into them, let's briefly talk about what that really even means. Risk adjustment is a method to allow for differences among patients, allowing for the different illnesses that they have and demographics, where they live in the country, etc., that can affect their health care outcomes. And basically it's a way of comparing providers across the spectrum of health care to level the playing field, to be able to compare provider to provider. It's assessment of the treatment effectiveness by each of those types of providers. It's allocation of funds for treatment based on how that risk adjustment looks. And it's really focused on reducing mortality rates, readmission rates, complication rates, and overall cost of health care. Some of the variables that impact risk adjustment are obvious examples that I'm sure many of you or most of you in CDI are already familiar with. Chronic conditions that have a huge impact on the health care of patients and a predictor of the cost going forward for those two types of patients. So starting with the Hospital-Acquired Condition Reduction Program, it is related to that PSI 90 composite score, and there are risk adjustment variables involved that are based on demographics of the patient, severity of illness of the patient, comorbid conditions that are present in that patient's list of diagnoses, and other factors that can affect this, like did they transfer in from another facility, where did they come from for care, how long were they there before a procedure was done on the patient, etc. And some of the diagnoses that are variables and impact that risk adjustment are diagnoses that reflect weight loss, obesity or BMI being too high or too low, renal failure, and renal insufficiency. The hospital readmission reduction program has been focused for quite a while, of course, on heart failure, acute MI, and pneumonia. And you can see on the slide that for fiscal year 2017, they've expanded the pneumonia category to include aspiration pneumonia and also sepsis as a principal diagnosis when the underlying cause of the sepsis was pneumonia. That would include, however, severe sepsis cases. Then you also see COPD as a focus of this program. The hip and knee replacements are a focus of the program, and they have added for 2017 CABG cases, patients that have had bypass grafts with coronary artery disease. The pneumonia risk variables, some of the examples that impact how pneumonia cases are risk adjusted are again listed on the slide. If they have a history of CABG or a PTCA, if they have a history of infection or sepsis, a renal failure or chronic renal insufficiency, lung cancer, CHF, etc. And just while we're talking about pneumonia, I'm sure that you're aware of the fact that one of the problems that we have with pneumonia is that the codes do split based on the causative organism, and often if we don't get any sense of that documented by the physician, we end up going into those lower weighted DRGs for pneumonia that don't really capture a lot of the severe, more complex pneumonias that many of the Medicare patients have in the inpatient setting. So we really have some work to do still with trying to get documentation improvement in this area. We also have the hospital value-based purchasing program that I mentioned earlier has been sort of being slowly implemented over time. And there are basically 4 domains that are involved in that. They were realigned for fiscal year 2017 that we're fixing to move into October 1. And they are focused on efficiency and cost reduction, patient, caregiver expectations of care and care coordination, patient safety, and obviously the clinical care itself and the quality of that care. Again, here's a list of the CMS version of the PSI 90 composite score. The 8 factors that we talked about earlier are listed at the top of the slide there. Pressure ulcer, iatrogenic pneumothorax, the CLABSI, which of course is the CBL or line-based, central line-based bloodstream infections, post-op hip fracture, a perioperative pulmonary embolism or DVT, post-op sepsis, post-op wound dehiscence, and an accidental puncture or laceration. And you can see on this the performance period as outlined for fiscal year 2016 and 2017 and the minimum of cases that have to be reported to CMS. And this also kind of shows you the claims-based outcome measures that I talked about before. These were in effect for this fiscal year that we're in right now. Patient safety, of course, is based on the PSI 90 measures. Mortality related to AMI, heart failure, pneumonia, and COPD. Complications related to the hip and knee replacements. And then efficiency, which is related to them measuring the Medicare spending per beneficiary. And the risk adjustment method for that is HCCs, and I'm going to spend a little bit of time talking about that in a few moments because I find people don't know quite as much about those. We also have these bundled care initiatives out there. Bundled payment for care improvement was created by the Affordable Care Act to test innovative payment and care delivery models that could reduce payment for Medicare, Medicaid, and children's care, but also at the same time to preserve or enhance the quality of that care. You note on that slide that I've pointed out that this is a voluntary program, and it basically kind of keys off of the DRG payment and is an extension of that DRG payment. The goal is to align payment incentives and healthcare incentives and cost-effective incentives for all the providers involved in the care of the patient. That includes the hospitals, the post-acute care providers, the physicians, and any other practitioners that are involved. And it really encourages all of the practitioners that are involved in the care of that patient to work together across all the specialties and all the healthcare settings. And this is really a huge paradigm shift for us to move into this type of a situation because, as you know, for all of these years, hospitals have always gotten paid one way, physicians have gotten paid another way, and that's been one of the sort of disconnects that we've had in working with physicians, is that how they got paid didn't have a whole lot to do with how we got paid in the hospital setting, and they weren't always as interested in how we were getting paid as how they are getting paid. So as you can see, these bundled payment methodologies are going to require everyone to really start working together as a team to make sure that we're giving the best care, but also doing it in the most effective and cost-effective manner. The initiators that can start an episode of care are acute care hospitals, skilled nursing facilities, physician group practices, home health, inpatient rehab facilities, and long-term acute care hospitals. And the episodes of care in this bundled payment initiative can be defined as either 30, 60, or 90 days post-discharge. They basically developed 4 models to be phased in across 2 different phases of implementation. Model 1 included and includes all the MSDRGs that we've been using for quite a while. Models 2 through 4 actually include 48 clinical episodes that providers can choose from, and some of the examples of that would be, of course, acute MI, a patient who has an AICD, cellulitis, diabetes, major bowel procedures, etc. Research on these episode payments has indicated that across the country, for the most part, inpatient costs are consistent hospital to hospital, and that's primarily because it is driven by that DRG payment. However, the variable issues come in the post-acute care setting with skilled nursing facilities in particular and home health care, and also the readmission rates. They find great geographic variation in cost across the country when they start looking at these post-acute care settings and when they start looking at readmission rates. So it's going to be a focus to try to figure out how to bring some more standardization in care and cost in those post-acute care settings. Sort of a subset of that bundled payment initiative is this Comprehensive Care for Joint Replacement, or CJR program, excuse me. And as you can see, it differs in some ways from the BPCI program. First and foremost is that it's going to become not a voluntary but a mandatory program in about 800 hospitals that are located in 67 MSAs that have a high volume of hip and knee replacements coming out of those DRGs on the slide 469 and 470. MSA, in case you're not sure about what that means, stands for Medicare Medical Savings Account, and it is a type of Medicare Advantage program or plan. This is a 5-year program that's beginning with discharges April 1 of this year and ending with discharges in December of 2020. One of the most significant things that I want to point out is this next bullet where it talks about the fact that hospitals have to bear all of the risk for the Medicare cost of care for all services given to that patient during that 90-day episode, not just the cost issues related to the hospital care, but everything that happens across the whole spectrum of that 90-day episode. The reason that CMS primarily did it that way is because typically physicians and post-acute care providers do not have the financial reserves or infrastructure to bear the risk for the cost of the whole 90-day episode of care. And basically what they're doing is setting prospective target prices that they want hospitals to meet for that 90-day episode of care, and then retrospectively they will go back and sort of reconcile everything based on how the cost looked compared to those prospective prices that were set. They're really going to focus, as I said, on variations in cost of care that are due primarily to the post-discharge services and the time frame. The episode for these is fixed at 90 days, so there's not going to be the 30, 60, or 90-day option. It's all going to be a 90-day episode of care. And it does include all the covered services except for Part D drugs for all providers listed on its slide: physicians, SNF, home health, inpatient rehab, and other outpatient services. And it also includes all related readmissions during that 90-day episode of care period. They also have to meet a quality composite performance measure that includes surgical complications, patient satisfaction scores, and patient outcomes in order to get those post-discharge reconciliation payments that I mentioned earlier. Now let's talk about HCCs for a minute. Those are hierarchical condition categories that are used for risk adjustment in those managed care programs or those Medicare Advantage programs that I mentioned on the previous slide. As of 2016, there are 31% of Medicare beneficiaries that are participating in Medicare Advantage programs. In addition to that, risk adjustment is also used for the Medicare Spending Per Beneficiary program. It is also involved in the physician value-based purchasing modifier that's has been being implemented over the last couple of years. It is also involved in accountable care organizations, payments, and the PACE programs, which stands for Program of All-Inclusive Care for the Elderly. And last but not least, it's also involved in the long-term acute care readmission prediction models that have been coming out. So what are HCCs? They are very similar to a case mix index. As you know, there's a relative weight assigned to each DRG, and you add all of those up and divide them by the Medicare patients that you treated to get your case mix index for inpatient care. So similarly to that, you add up all the HCCs and their risk factor for all the patients that you treat and sort of divide it by the patients, and you get this risk factor or risk coefficient that's assigned to different patients. They are diagnostic categories just as DRGs are, and they are assigned to the patient based on demographics and the I-10 diagnosis codes. There are about 9,500 codes, I-10 codes, that are assigned to an HCC currently. That includes both acute and chronic conditions, and 75% of that 9,500 codes are on the CC and MCC list for the MS-DRGs as well. HCCs, like DRGs, group patients that are not only clinically similar but have similar cost patterns to predict their future healthcare costs and to allow them to do comparisons for quality across providers. However, as you can see on this slide, they find that the HCCs are more predictive of readmissions and future costs than the MS-DRGs have proven to be for the inpatient care. There are currently 79 HCCs. Each one has a risk value or weight similar to the relative weight of a DRG, and that risk value, unlike the DRGs, can change from year to year. There are some different HCC models out there, but we're focusing primarily on the one that CMS has developed. And as you can see, they only use diagnoses from inpatient and outpatient hospital and physician data. They base the payment set for each member in the Medicare Advantage plan based on all the HCCs that apply to that particular patient and the cost for the multiple chronic diseases if that patient has those. There is also a disease interaction adjustment factor applied when you have several things that sort of are related to each other, and there's sort of a hierarchy of more severe and less severe conditions. They also do demographic adjustments for the age, sex, original Medicare entitlement, disability, and Medicaid status. And the diagnoses from the base year are used to predict payments for the next upcoming year. There is a participant guide out there that was developed by CMS. There are two out there. One was dated 2008 and one was dated 2013 that have a great deal of information about this if you are interested in looking further into that. So the characteristics of HCCs, you can have more than one HCC assigned per encounter. That's sort of similar to the way we have multiple APCs that can apply to an outpatient encounter. Basically what you need to do in order to get the best risk adjustment impacting your reimbursement is to capture every HCC diagnosis that would apply every year. In that example that I have up there, status post amputation, if that happens to get documented the first year that this patient's record is started, but it drops off at some point down the line, you're not going to get credit for that as you go forward with the risk adjustment for that patient going forward. So anything that affects that patient's risk adjustment is going to have to be documented every single year in order for it to be counted. The diagnosis of diabetes mellitus triggers a lot of HCC payments, but again, the particular HCC is going to depend on whether the patient has diabetic complications, how many, and what type those are. So specificity of those diagnoses is going to be very important. As you can see there, diabetic peripheral angiography with gangrene is going to count for more in risk adjustment, obviously, than a patient that does not have gangrene. No sequencing is involved in the HCC assignment like there is in a DRG. Also does not involve procedures. And various settings are included in this, not just the hospital setting or the inpatient setting. Documentation from a broader group of provider types and specialties can be used for coding than you can use for DRG coding. That includes PT, ST, OT, social workers, certified wound care nurses, etc. Hospitals that have contracts with a Medicare Advantage plan may receive bonuses for coding for HCCs. So as you are working with your CDI program and your coding professionals, you need to figure out a way to sort of layer the coding for these different things on top of coding for DRGs, and I'm going to talk about that a little bit more in just a minute. Hospitals and physicians that have managed care contracts that are not looking at HCCs and making sure that they sort of capture documentation and codes for that are often leaving a lot of reimbursement dollars on the table. Many times hospitals and physicians are getting paid on multiple methodologies, including a managed care plan, and don't even realize it. So it's very important that you, if you're working in a CDI program, that you take advantage of looking into that and find out if you have any of those Medicare Advantage plans that you need to take into account as you're trying to improve the documentation that leads into proper coding for those. So the risk adjustment factor that I mentioned earlier, each patient gets a score for the calendar year, and it changes each year. And there is a hierarchy of HCCs. The risk factors range from 0.118 up to 2.4888, and they do give information on that member's expected health care cost. One is sort of an average patient that uses average resources. Anything less than one is a patient that's very healthy and uses fewer than average resources, and obviously greater than one is a patient probably with a lot of chronic conditions that uses greater resources. So they add up all the HCC weights for each particular member or patient, and they include in that the age, sex, Medicaid status adjustment, etc., and come up with that score for that particular patient. If you have similar or several diagnosis codes that fall into one HCC, the one with the highest weight is going to trump the others, and they will be added into that, figure out the score for that particular patient. There's also an adjustment factor when you have clinically related conditions, and again, I'll talk about that again in just a minute as well. So just to give you sort of an example here, the diagnosis code is going to drive that risk adjustment score, and that's going to drive the reimbursement. Inadequate documentation is going to take away reimbursement dollars, and obviously good documentation is going to increase reimbursement dollars. Many of the unspecified codes are not captured in the HCCs, so that lack of specificity is going to cost a reimbursement to the hospital and or physician. Again, an example here is bronchitis not otherwise specified, is not an HCC code, but simple chronic bronchitis is captured as an HCC, and you can see the relative weight for that. And basically, for every 0.01 increase in that risk score, you get a 10% increase in reimbursement from CMS. So the conditions that map to the HCCs are listed here. A lot of the high-cost conditions that are obvious, like cancer, heart disease, hip fractures, etc. It includes both acute and chronic codes. Status codes, interestingly enough, there are some of those that have a big impact on this as well. Etiology manifestation codes. Common conditions, rare, curable, non-curable, congenital. The big factor here is that it has to meet the MEET criteria. In other words, they had to have monitored, evaluated, assessed, or treated that particular condition in order for it to be counted in the HCC rating. They also exclude diagnoses that don't predict cost very well, such as appendicitis, or diagnoses that have a lot of variability in how they're coded, how they're documented, how they're treated, etc. And they also don't look very carefully at diagnoses that come from lab and radiology and home health claims. Those are not considered to be very reliable, and often they indicate rule-out diagnoses anyway. Some of the risks with the HCC codes are, first and foremost, most of the documentation for these codes does not come from an inpatient hospital record. It comes from an outpatient record or a physician office visit. And the documentation specificity is often not nearly as good in those two arenas as it is in the inpatient setting, as you probably are already aware. Also, many of the providers, especially in the physician office setting, often directly assign codes for the encounter without any I-10 coding education, without access to an encoder or the official coding guidelines or any of the tools that help people make sure that the documentation and coding is appropriate and correct. Often they use still some super bills or EMR drop-down menus that don't have the full spectrum of diagnosis specificity and diagnosis codes that are available, and so that specificity is limited because the options available on the super bill or the EMR drop-down are not all there. Also, you have to document the diagnoses just as you do in the inpatient setting. You can't interpret lab values or assume diagnoses based on medications or orders. They need to be documented to the highest level of specificity, just as for the DRG setting, because obviously the specificity greatly increases the likelihood that they will map to an HCC and that they will map to a higher weighted HCC if appropriate. Also, that last bullet there I want to talk about for just a moment, the diagnoses that are coming from that outpatient encounter or that physician office encounter or the inpatient encounter have to be documented in a section that the coders can code from. And that CMS manual that I mentioned earlier is very specific about this. They cannot code current conditions from problem list, medical histories, or super bills. And if, for example, the physician documents a chronic condition such as congestive heart failure in past medical history, which I see extremely frequently done in the inpatient setting, it is not going to be able to be coded as a current condition for HCCs. So there are a lot of things about how the documentation has to be done in the outpatient record and the physician office record that either allow you to pick up these things or keep you from picking up these things in an arena where there's not a lot of focus on really good record keeping and documentation like there is in the hospital inpatient setting. The interaction of disease factor that I mentioned earlier, this shows you that if you have diagnoses that are sort of clinically related, it affects the HCC that it's mapped to. Congestive heart failure goes to HCC 80. If you have COPD, it goes to 108. Cerebrovascular disease has several HCCs that it can map to. Coronary artery disease goes to 81 through 83. And you can see at the bottom bullet there some examples of adjustment. If you have diabetes along with congestive heart failure, there's a factor that's applied to determine what the relative weight or the risk factor weight would actually be for that. Same thing if they have diabetes with cerebrovascular disease or COPD, etc. So they do apply that when you have a lot of clinical chronic conditions that have interrelationship with each other. Now let's switch gears for a minute and talk about APR-DRGs. There are some states that have many payers that have been using APR-DRGs for quite a while. I live in Alabama. We don't have any payers that use APR-DRGs regularly, although Medicaid is about to transition to that in Alabama. So hospitals, some hospitals are very familiar, and some CDI people are very familiar with looking at documentation specificity for APR-DRGs, and some are not. Basically, APR-DRGs assign a severity of illness score or an SOI score that ranges from 1 to 4, based on how that impacts physiological decomposition of the body systems and the resources that are going to be used to take care of that patient. And they also assign a risk of mortality score, which represents the likelihood of dying. The factors involved in that in assigning the APR-DRG involve the SOI and ROM scores, prognosis, treatment difficulty, need for intervention, resource intensity, etc. Each SOI and ROM score has a default value assigned. However, that can be raised or lowered or excluded depending on its relationship to other conditions that that patient might have. For example, if a patient has UTI as a secondary diagnosis, the default SOI for that is a 2. But if the UTI is the principal diagnosis, then the SOI goes up to or goes down to 1 rather. Age is a modifying factor that also impacts the SOI level. And basically the SOI levels contribute to the mortality score because they help determine the observed mortality divided by the expected mortality to give you that mortality to score. And the last bullet on this slide shows you some of the diagnoses that may or may not be coded regularly, and even if they are coded, don't always get in the top 25 that goes on the claim, that do have an impact on the SOI level. So just take a look at that when you have some time to make sure that you capture some of those if you see them regularly, and try to get them sequenced in the top 25 so that you can get credit for that. This is just kind of an old example, but it gives you, again, a sense of how the specificity of the diagnoses impacts the APR-DRG assignment. In this particular case, the patient is, has a principal diagnosis of colitis, and the secondary diagnoses on the left side have very little specificity documented. The SOI is 2, and the risk of mortality is 1. You see the DRG, relative weight, and the length of stay assigned to that. While on the right side, when the physician adds the additional specificity, that acute kidney injury with acute tubular necrosis and the listing the stage of the chronic kidney disease raises the SOI from 2 to 3, and it also raises the risk of mortality from 1 to 3. It raises the DRG relative weight and the length of stay assigned to that particular patient. Now let's talk about this for a moment. Nobody can answer where I can hear you, but I would like for you to ask yourself and answer to yourself whether you think the electronic medical record has improved documentation. I've asked this in several settings, and most people say no. And this quote here sort of sums up what I think is the problem. We've really lost the sense of the narrative of the patient's story because of the nature of the EMR and some of the things I'm going to talk about in a minute. It's very difficult in today's world to follow the patient's story from beginning to end and figure out what really happened. One of the problems is that we have problem lists that don't get reviewed and updated, and they're inaccurate. That second bullet up there in particular, cut and paste or cloning or record bloat, it takes so much longer for CDI people and coding people to read the information in the electronic record. It's very difficult to tell what's current information and what's old information pulled forward. Depending on different doctors that are looking or documenting in the EMR, they will pull forward different problem lists, and they don't all coincide with each other, so it gets very confusing. It's very difficult to tell what's really going on. One of the biggest problems with the cut and paste especially is that the rule-out diagnoses that they think might be happening when the patient first presents for care don't really ever get clearly ruled out or confirmed during the course of the stay. There are a lot of inconsistencies between the different physicians. They have their own set of electronic templates for their progress notes, and they don't always agree with what they document. There are a lot of errors in documentation where physicians don't appear to know how to correct that appropriately in an electronic setting. And there are templates that can sometimes provide an incomplete picture of the patient's episode of care. Also, traditionally, in the beginning days of CDI, everyone was obviously focused on trying to make sure that they captured documentation to get the right codes to get the best reimbursement. And certainly that is still an important issue. But as we move forward with the electronic record and with these new payment methodologies, we're going to have to be more concerned with making sure that we're trying to get accurate and consistent documentation in the electronic record. As I mentioned at the beginning, to have documentation integrity. This physician spoke at the Society for Clinical Coding at AHIMA a couple of years ago, and his premise is that if you pursue reimbursement with your CDI program, you will miss the high-quality record, but if you pursue the high-quality record, the proper reimbursement will follow. So basically, to give you a picture of where CDI has to move to from where it is today, the goal is to integrate CDI, quality, and coding to work together to achieve a complete and accurately documented clinical picture for every patient, every encounter, every claim across the whole healthcare continuum. Collaboration is critical, and it's got to be centered around patient episodes of care across all the settings because, as I mentioned, those bundle payments are going to start focusing on 30, 60, and 90-day episodes of care and a real focus in the variation in cost and quality in those post-acute care settings. So they've got to really have a focus of improving documentation across all those settings. Coders have got to be able to apply the coding guidelines consistently and improve communication with non-acute care peers. And quality teams have got to make sure that the clinical practices are following the measures and the guidelines during each encounter and monitoring the outcomes of the patients once they are discharged from the hospital. Revenue cycle has got to track the cost across the entire episode of care. And the executive leadership has got to develop affiliations with post-acute care providers to make sure that everyone is working together to integrate and share patient information, control cost, and make sure that the care is as excellent as possible. So the CDIs of tomorrow have got to really look beyond CCs and MCCs and DRG assignment only. Also involve looking at risk adjustment for the quality measures and HCCs and other reimbursement methodologies out there, looking for things that impact AP or DRG assignment, the severity of illness score and the risk of mortality score, etc. Example there would be the fact that obesity doesn't have any real impact on AP or DRGs, but it has a significant impact on how hospital is risk adjusted based on the PSI 90 scores. So you have to, as I said earlier, layer these different things into the process in terms of obtaining the best documentation and helping it translate into the best codes for all of these different things that are impacting future reimbursement. Because CDI and coding professionals today are often working remotely, they've got to find different and better ways to communicate with each other and to communicate with physicians to make sure that they work together and build those relationships. Many feel that the ideal CDI team has got to be a hybrid where you have some people off-site and some people on-site because there still needs to be some face-to-face time, especially with physicians, to build relationships and educate physicians. You also have to develop new and different ways to query physicians through email process or an EHR interface to make sure that you can capture that information and obtain it in a timely manner from the physicians. This is an example of sort of what CDI of tomorrow has to look like to incorporate all these different factors. This is a claims-based PSI-7, the central vein CVL-related bloodstream infections, divided by all medical and surgical patients. CDI is striving to risk adjust all the patients, not just those that have CVL-related infections. CDI and quality are working together to define the patient population so that coders can report the most accurate codes. Because, for example, CVLs are coded differently with PCS codes than midline catheters, so you have to make sure that you are honing in on the specific PCS codes and diagnosis codes that fully describe that patient population correctly. Also, you can see some of the types of patients that are excluded from that patient population are people that have cellulitis, who have subsequent encounter or sequela rather than a current encounter, who have neutropenia, pancytopenia, etc. They have to do a concurrent review for all CVL bloodstream infections to determine severity and risk, and then set up a second level of review prior to billing to make sure that they have an accurate patient population so that documentation and that factor that goes to CMS is as accurate as possible. So it's important to manage opportunities and mitigate risk in the CDI of today and tomorrow. Obviously, in the inpatient setting, we're still dealing with the whole medical necessity for inpatient versus outpatient services. We do need to optimize the MS-DRG assignment based on obtaining the most accurate and comprehensive documentation and codes. We do need to capture the specificity that relates to SOI and RON for APR-DRGs. And as I said, if you have managed care contracts, you do need to also be aware of the diagnoses that affect the HCC tables and try to obtain the specificity to capture those by the physician, that documentation, and make sure that those are coded appropriately and sequenced. As you can see, there are 42% of the HCC diagnoses are CCs and 16% are MCCs, but there's a whole other 42% of the diagnoses that map to HCCs that are not involved in the MS-DRG arena. In the outpatient setting, we also have the same issue of medical necessity, and as you may or may not be aware, depending on whether you work with outpatient stuff, those medical necessity edits are code specific. So that gets right back to how specific the physician documentation is. And often that medical necessity in the outpatient world comes directly from either codes or diagnoses, narrative diagnoses from physician office personnel who do not have the real training in documentation and coding that the facility people would. You need to make sure that you get documentation of all comorbid conditions because all of those affect HCC mapping, and make sure that you have manifestations and etiologies linked clearly in the documentation. Make sure you have accurate and complete coding of the diagnoses, and that claims include all diagnoses that were documented and meet the MEET criteria, that were monitored, assessed, evaluated, assessed, or treated. So some of the new challenges for CDI, there are a lot of specificity decision trees embedded in the EMRs of today. Sometimes the physicians don't know correctly and they have a lot of choices and they don't always make the right choices. The example on the slide there is a patient with fluid overload that was non-compliant with dialysis, and they also have a secondary diagnosis of CHF. The physician has to be able to document clearly that that fluid overload is related to the kidney disease and dialysis and not congestive heart failure, because ICD-10 coding sort of rolls fluid overload related to CHF under the CHF guideline. Also, all of those specialists there, CDI, coders, case managers, and revenue cycle have to work together across the whole spectrum of care to make sure that they are, the workflow is going smoothly, that processes are improved, that documentation that can affect quality and reimbursement is being targeted and worked on, etc. And then, as I said, figuring out a way to have queries worked into the MD workflow to improve response and communication. Some people recommend working with IT to create a shared progress note to clear the physician as a part of the electronic record, and actually putting that into the medical record process for completion so that it's flagged for our physician response and signature. A lot of different options out there, but definitely a challenge in terms of what is most effective in your particular organization with your particular medical staff. Also looking at documentation and coding as an indicator of future reimbursement issues. Where is it inadequate? What workflows are causing problems? What physicians need additional training? And clinical validation, which we're going to talk about some more in a few minutes. As I said, looking at documentation across the whole continuum of care, because it's all going to come back to reimbursement for hospitals and physicians based on that whole episode of care, including post-acute care in many cases. Looking at red flags that payers are watching for that trigger reviews and denials. The clone progress notes that appear to be generic rather than patient-specific are a huge red flag to payers. PCS procedure codes, they know that that's more difficult to use, and so they're kind of targeting some of those to make sure that they're being done correctly. Unspecified codes, it's the #1 reason why we have denials, and those need to be restricted to exceptional cases only. Also, we have several thousand new codes going into effect October 1 for ICD-10, CM, and PCS. We need to evaluate how those are going to impact our patient population and where we have opportunities for improved or lost revenue. In many cases, it's going to require additional specificity by the physicians that we haven't had to ask them for this first year. So we, CDI and coders both need to get in on the front end of this to try to educate physicians ahead of time about some of those areas. And that education can be targeted, by specialty area to the physicians and the things that affect their particular specialty. Also making sure that we are looking at upcoding and downcoding to make sure that the documentation and the coding and the risk adjustment is as accurate as possible. Looking at software issues that are causing problems and keeping us from obtaining the best data entry or the best documentation that we need. Quickly, I want to talk about the clinical documentation versus coding issue. This is kind of a new thing that's come out, in particular in the last couple of years, where the payers are downgrading DRGs or even denying payment because they say that a diagnosis that was documented and coded by the physician does not have clinical substantiation in the record. And there are different positions that different coders and CDI people have had about this issue, but I want to point out a couple of things that have just come out recently. From the RAC scope of work in 2013, you can see that clinical validation was written into their scope of work as something that they can and are going to do. And they go on to state that clinical validation is beyond the scope of DRG coding validation and the skills of a certified coder. This type of review can only be performed by a clinician that has approved coding, or a clinician that has approved coding credentials. 2017 coding guidelines that are about to go into effect for October 1 state that code assignment and clinical criteria should be based on the provider's diagnostic statement that the condition exists. That's sufficient to code that. A lot of coders have been asked not to code conditions that weren't substantiated within the record because it's counting against them as a coding error, but basically the coding guidelines are stating that if the doctor documents it as a diagnosis, then code assignment should be based on that, not whether the clinical criteria were met within the record. Also, there's a whole journal, July 2016 article about this whole issue and the next level of CDI. If you have not read that, you need to acquaint yourself with what that talks about. And it talks about the importance of making sure that the medical record accurately reflects the clinical scenario of that patient. And it involves collaboration among all the people involved in the care. They do believe that clinical validation is subjective and that it is beyond the scope of CDI and coding professionals to define diagnoses. They are not established to do that, and even CDI professionals that have an MD behind their name, if they're not part of the treating team, it's really beyond their scope. That's also reiterated by Coding Clinic and what they have come out with. They don't feel like they can establish clinical indicators to guide CDI and coders. They feel like that's beyond their scope as well. However, we still have to figure out, how to deal with this. Also, the practice brief by HEMA does state in the updated 2016 version that when you have a situation like that, where you need to get some additional clarification from the provider, that a query is the appropriate way to do that. So the bottom line of that is, for CDI and coding professionals both, we do have to deal with clinical validation, and we have to have some type of developed escalation process to make sure that we capture everything that's there. And I'm not going to walk through every single thing here, but you need to have it clearly outlined so that you can communicate with the attending physician, communicate with the physician advisor. If clinical indicators appear to be lacking for a particular diagnosis, it's documented, and have a good process in place to involve the clinical review that's needed to look at those situations. One of the biggest barriers to CDI success is physician engagement, and because we are about to move into the realm of reimbursement where hospital and physician reimbursement is going to be linked and intertwined, we have an opportunity right now that we've never had in my career to get the ear of the physicians, because no longer can they say, don't really care what the hospital gets paid as long as I get paid. That's changing, and so right now we have an opportunity to explain to them how documentation translates into profiling, risk adjustment, reimbursement, and how physicians and hospitals are sort of in it together. You can see on the bottom of that slide there that in CDI programs, from a 2015 survey, 89% of the programs did not have a physician advisor or a champion. That is a huge issue because it is very difficult to have a successful CDI program if you do not have a physician advisor or a physician involved in that. You need to have physician documentation going on all the time. It needs to be specific to those physicians and what their issues are as much as possible. You need to involve the PAs and the other service line leaders. You need to have some type of face-to-face time with physicians periodically with your CDI people. Some people have developed a system where the CDI people can actually round with the patient care team, and that's an ideal situation if it's possible for you to do that at least periodically. It's a wonderful opportunity to develop those relationships between CDI and physicians and develop communication, teaching moments, and that relationship trust. It's very important to help educate physicians about how MACRA is going to impact them, and if you're not aware of what's happening with MACRA, you need to acquaint that because it's going to be to physician reimbursement what DRGs were to hospital reimbursement, and it's going to have a huge impact, and it will help you to get the physician's ear if you educate yourself enough about how that's going to impact them to use it as a teaching opportunity about documentation specificity and quality. They don't know a lot about cost. They often don't know how much tests cost, how much medications cost, etc., and they're not aware of how that impacts their scorecards, their severity, risk, adjustment, mortality scores, etc. And so often they can improve all of those things just by improving the quality and specificity of the documentation that they put in their records. The query process I've already talked about before. It's going to be very important to develop a real effective way of that. Some facilities have actually worked with their natural language processing vendors so that they can actually auto-generate queries for specificity in real time while the physician is up on the floor working in the EHR. That's something that you might want to consider looking at down the road. You need to make sure that the queries are clear so that the physician knows what's being asked. You need to figure out the most effective way to transmit that information to the physician. Often doing it while they're on the floor working is going to be more effective than sending it off in an email, but you have to figure out what works for you. And you need to make sure that you educate them on clinical validation. What are the preferred clinical criteria out there for sepsis or for malnutrition or for acute kidney injuries, etc., and to try to get them to document in their record what criteria they're using when they make a diagnosis of one of those things. Also, a physician advisor, as I said, is critical, and this is sort of a profile of what a physician advisor, the ideal physician advisor would look like, and I'm just not going to read that to you because you can look at that yourself. The CDI team involves all of these different aspects, including patient access, which is kind of a new thing that CDI hasn't looked at too much in the past, case management, the revenue cycle, denials management, and developing CDI for ER, outpatient, and same-day surgery. Much of the care is shifting to the outpatient side. Very few CDI programs concurrently or currently are doing outpatient CDI, but I think that everyone is going to have to move in that direction. And you can look at this slide to see some of the information about denials and the number of cases that are involved in that as well. These are some of the areas that are important to focus on for the emergency room. Obviously, medical necessity is up there, procedures that are done in the ER, etc., and making sure that the diagnosis specificity is as clean as possible and making sure that the impression matches up with the physical exam within the body of that ER record. Some other issues relate to the cloning, outdated problem list, and other things that I've talked about before. When possible, you should involve an RN that works in the ER to help you with the CDI process because they can be very helpful in educating the physicians. Same thing with this outpatient CDI. It cannot mirror your inpatient CDI because it's a totally different ballgame. Much greater volumes, much shorter lengths of stay, much different guidelines and code sets and claim forms involved in it. A lot of different things. Greater role of non-physician documentation in the outpatient setting. So it's much more complex than the inpatient CDI, but definitely a focus that we're going to have to move to. Again, the key areas of focus in the outpatient CDI are on this slide here, and some of the other documentation issues that are similar to what I've already talked about with inpatient and ER. Best practices for success, there are some on this slide here. Making sure that any CDI efforts and audits and denials, that feedback is given back to the physicians so that they know what their problems are and try to use their competitive nature to your advantage in trying to get them to change their behavior. Use all of the technologies that you have. Obviously, CDI people often aren't as trained in coding as the coders, and so in the outpatient setting, having a good encoder that has a lot of the medical necessity edits and the documentation needs for outpatient and all of that can be a wonderful tool, as well as a lot of the other tools that you have available to you in your electronic setting. So the value of CDI, as we close, is to basically support improved quality of care, to make sure that the documentation fully supports medical necessity, it's complete, it's accurate, it's compliant, it can defend and reflect why you did what you did to the patient, that you gave the best quality that you could, that you were as cost effective as you could, that you tried to give the best quality care based on the quality monitors and measures that are out there, etc., to make sure that across the whole continuum of health care for an episode of care that everyone is involved in working together to give the best quality care that they can with the resources that they have and to do it in the most efficient manner. So with that, I've got a lot of references here. I'm sorry I ran right up to the hour, and I apologize for that. A lot of material to cover, but we probably don't have any time for any questions, but we will make sure that the questions are responded to in an email. Karen, do you have anything you want to say now?
Thank you, Joy. That was wonderful. And again, remember, you can get your handouts by clicking on the handout button, and it'll have you click on the presentation, and that way you'll be able to download it or print it from your facility. Please remember also that you will get an email with an evaluation survey. Once you submit that, it will send you the CE. If there are other people in your facility on this call who did not register, you need to send an email to Sharon and also copy their CE certificates. Thank you so much, Joy. That was awesome. It was very, very helpful, great information, and we appreciate everyone being with us today, and we hope to see you soon. Thanks, everyone. Bye now.